to start again. We're ready to start again.
Thank you, everybody, for your forbearance. So, unfortunately, technical difficulties. Am I on? And go. All right. So, we're going to do this a little differently. Rather than showing it off the desktop, it's coming via the web. So, I can't seem to get to the view screen, but we'll keep on going. All right. So, I did want to take a minute to just scope out the burden of asthma in the U.S. So asthma is a chronic disease that affects 25 million people, including 7 million children. And the good news is that it's a manageable chronic disease. We have good medicines that can control symptoms and prevent asthma attacks. The bad news is that we've got a real disconnect between what's possible and reality. So as of 2010, there were over 12 million people reporting asthma attacks, which included 4 million kids. There were over 1.8 million ED visits for asthma-related care and almost 500,000 hospitalizations for asthma. While deaths due to asthma are very rare, these are considered preventable deaths. And so over 3,000 deaths in the U.S. Annually due to asthma. And 17 million doctor's visits and a huge price tag, both on the direct medical care and the indirect aspects of asthma in terms of missed work, of $56 billion spent related to this condition. But asthma is not spread homogeneously throughout the population. So there's certainly geographic variation. So asthma prevalence rates range from a low of about 6% up to 11%. I think Vermont is one of the highest. But Michigan is certainly in the higher tier in terms of asthma prevalence. But even in given geographic vicinities, the burden of asthma is not shared uniformly across the population. Asthma is one of the diseases where there's some very distinct health disparities. Now I'm going to show you a little bit about asthma in Michigan. There's a higher burden of disease amongst people of low income. This slide reflects asthma hospitalization rates from a recently published MDCH report showing a much higher rate of asthma hospitalizations among low-income people. Similarly, there is disparity by race. The green bar represents hospitalization rates on the left and mortality on the right amongst African Americans. And you can see that even though African Americans are a small proportion of the Michigan population, that community has the larger rates of asthma morbidity and mortality. Not surprisingly, there's geographic variation within Michigan. You can see that areas of our state that have higher proportions of low-income people and higher proportions of African Americans are also the same regions that have higher rates of asthma hospitalization. Detroit is sort of the epicenter of our asthma hospitalization problem or challenge, shall I say, in Michigan. Not coincidentally, these are also the areas of our state that have urban centers. It's where the population is, but it's also where pollution sources are. It's where our highway networks are. It's where our point sources from industrial sources are as well. So one of the big questions in environmental epidemiology is that happenstance, coincidence, is that causal? It's certainly an example of environmental injustice where people who are most vulnerable are getting exposed to the highest burdens of pollution. And the joys of working on the web. All right, so the next little bit is talking about our partnership. So some leaders of community organizations in Detroit looked at these statistics, and they could look around them and they could see people struggling to manage asthma in their communities. And they said, we want to do something about this. And there was, back in 1997, an effort to partner with U of M researchers to try to tackle these problems. And that was the beginning of Community Action Against Asthma. It's a community-based participatory research partnership. We try to share the activities of doing research together. We try to come up with the research questions together. We work on developing our research instruments together when it comes to operations and actually conducting the study. The partners in Detroit are right around the table helping us make that happen. And I think the principle is that we all bring our own expertise, whether it's the academic knowledge about conducting research or whether it's the local knowledge on the resources and the strengths of the local community. Yeah. All right, well, maybe we'll go back to our old friend. We'll get it, one way or the other. Ah. It's never good when you, the only thing worse is the blue screen of death that comes. I do have, no, I've got the flash drive, so let's go back to that. Okay, go. All right, so here's a list of our community partners. It's a series of different kinds of community organizations, some focused on health, some focused on economic development, some focused on the environment. We have a community activist who's a former public health nurse, and then several researchers from the University of Michigan. So switching gears a little bit, talking to, so how is this community group going to attack asthma? I think the goal was not to go through the healthcare system and try to make a better drug or better healthcare delivery. The goal was to try to understand what's going on in communities and what can people do in their own communities to try to make this problem better. And asthma is a perfect condition for considering this because it is a condition that's very much affected by the environment. As you can imagine, the things you breathe in from the air are going to affect your lungs. And there's extensive medical literature showing that that's the case for asthma. So what are the things in the air that can affect asthma? Certainly there's outdoor air pollution sources, what we call from point sources or a smokestack, but there's also what we call mobile sources, or things like cars, trucks, and trains, where you have engines that are burning and often going right by populations. There's also inorganic sources of dust that can be irritating to the airways. But of course, there's also indoor sources, and although that's not going to be the focus of this particular presentation, people spend a lot of time indoors, and so we can't forget those sources as well. Okay, so why focus on roadways? First of all, there's an increasing number of vehicles on the road, and we're driving farther and longer than we used to. It's estimated that 30 to 40% of North American urban residents live in a traffic-affected area. And traffic-related pollution is not just one thing. There's a series of different gases, particles, toxics that are emitted either from the tailpipe or from brake and tire wear. Previous studies have shown large increases in these pollutants, especially pollutants specific to diesel truck exhaust, in locations that are affecting people. So schools and homes, particularly those that are situated right along the highway. And increasingly, we're understanding the biologic activity of those diesel emissions as being important for health. So just talking about trends for a minute, this slide condenses a lot of information. The scale is different in the left-hand side, but you can see if this dark green line represents sort of an overall estimate of the 6 common pollutants that are regulated by the EPA, called the criteria pollutants. We can see that clean air regulation has been successful in gradually reducing the level of those pollutants in our air over the last 30 or 40 years. Conversely, if you look at vehicle miles traveled, that's going up. So if we project to the future, mobile sources are going to become an increasingly important source of the pollutants that are affecting people with asthma. So just quickly, here's an overview of some of the evidence that we have that truck traffic or diesel traffic affects health. This is a Dutch study looking at the density of trucks going down the road related to the lung function of asthmatic children. And the downward slope suggests that the more trucks going by your place of residence, the lower your lung function, which is bad. This is another piece of evidence showing that in a test of bronchial hyperreactivity, or how twitchy or sensitive your airways are, if you breathe in clean air prior to the test, you get one measurement, and if you are pre-exposed to diesel exhaust, you get lower measurements or more twitchiness. So again, diesel is somehow affecting the airways, making it more sensitive to other things that may be in the air, like pollens or allergens. And finally, here's a study from Southern California that links new onset asthma to proximity of a child's home to major roads. So this was a large study of over 4,000 children gathered from 12 different communities in California, and the communities themselves had a gradient of different pollution exposure. And they monitor kids for up to 8 years looking for new cases of asthma. And the Brunekreef study that I showed you before had to do with the volume of truck traffic going by the house. This shows that the physical proximity, the distance of the home to the highway is also important. So some of the emissions that are coming from tailpipes change dramatically over the quantity of the pollution changes dramatically over very short distances. So once you get up to 300 meters from the highway, you have a baseline rate of asthma incidence, but the closer your house is to the highway, the higher the odds that you will develop new asthma. All right, so let's talk about the local situation for pollution. So I showed you previously that asthma prevalence was not heterogeneous across the country. Well, pollution issues are not heterogeneous either. And the colors are indicating the number of different pollutants that have been problematic in these counties. And the quick 10,000-foot view shows you it's the same urban centers that are having the asthma problem that have the pollution problem. If you focus in on Michigan, Chicago has a lot of pollution. A lot of this pollution kind of drifts over across Lake Michigan, and so some of the counties in southwest Michigan can have some pollution issues on some days, but the real focus is in southeast Michigan, especially Wayne County. Just like in the national trends of asthma pollution over time, some local monitoring of air pollution. This is over a shorter time scale, but you can see due to different changes in both composition of our fleet, tailpipe emissions, change in fuel composition, some increased enforcement, we are seeing a declining trend in certain pollutants overall. That's the good news. Sounds great. Problem is we're still having days of bad air quality. So the air quality index, or the AQI, is sort of a composite measure of when there's poor air quality in your area, and there's 5 different levels of poor air quality, but at sort of a medium level, the air becomes unhealthy for sensitive groups, and at sort of a medium-high level, it becomes unhealthy for everyone. And if you count up the number of days that we have unhealthy air, that's the total size of the bar, clearly there's an improving trend over time, but we're still having blips, right? And this should be 0. There should be no days when we have unhealthy air, especially if you're somebody who's particularly sensitive. All right, so why do we care about diesel exhaust in Detroit? Well, there's certain aspects of Detroit that make it a particularly hot topic here. So first of all, Detroit has a network of highways that cross right through populated areas with high-risk populations. We have minimal public transportation infrastructure, so more people are on the road. And because of the international border crossing with Canada, there's a large volume of truck traffic coming through Detroit. They've reconstructed the connector between the Ambassador Bridge and the highway system, but for a long time those trucks came off the bridge right through the neighborhoods and sort of idled in the neighborhoods right before getting back on the highway. Even with the new connector, especially with discussion of building a new bridge, there's still just a lot of traffic right near where the people are. Okay, so we know a lot about asthma, about air pollution, about diesel, but where are the knowledge gaps? So with these changing exposure levels over time, do Detroit children with asthma still experience roadway-associated health effects? We talked about roadway exposures being complex mix. What aspects or components of these exposures are driving the health effects? To some degree, it's a little bit of a black box. Breathe in diesel exhaust, get out sick kid on the other end. What happens in the middle? You know, what's happening biologically? What are the pathways by which that happens? And is there something that we can do to try to alter that? And can we understand that better if we measure biomarkers or other indicators of health? And then how do the complex physical and social environments interact with each other, and what can be done about it? All right, so CAAA was formed with the goal to try to understand the spatial, temporal, and composition of the exposures. The studies that I'm going to talk about today are an observational cohort study that's going to look at associations between roadway, air pollution, and asthma health. We're going to do some very detailed health assessments of asthmatic children living in defined zones near or farther away from highways. And then we're going to do a detailed assessment to the exposure. And I would just say those 2 components of this study were much more sort of intensive than what had come previously. And then we're going to use our statistical methods to try to find the links between the exposures and the health effects. So while it's a big study and we have many hypotheses, the ones that I'm going to talk about today have to do with zones of residence. So our first hypothesis is that children with asthma living in close proximity to highways are going to have poorer health than children with asthma from the same neighborhoods living farther away from the highways. And it's key to look at children in the same neighborhoods because there are a lot of unmeasured covariates related to usually income level and racial factors that you can control for by drawing people from the same small geographic area. Our second hypothesis is that we're going to look specifically at truck traffic, and we're going to test whether children with asthma living close to highways, specifically that carry high volumes of commercial truck traffic, have poorer health than children with asthma who live far away from these particular kinds of highways. So the data that I'm going to show you today is actually drawn from 3 studies that ran simultaneously, called one diesel, one nexus, and one airways, multiple funding sources, many collaborators, but it basically includes our Detroit partners, our researchers at the U of M. EPA was a collaborator on the Nexus study and did a lot of our exposure, helped us with a lot of our exposure assessment network. And then finally, the children and families who participated did a lot of work by enrolling in the study and continuing for up to 2 years. Let's start with recruitment. So our goal is to try to find children who have asthma or symptoms consistent with asthma in the school age range from 6 to 13 years old who live in 3 exposure zones around highways. So we started off at looking at 4 highways in Detroit. This is I-94 and this is I-75 in red. Those are the interstates. Those are the ones that carry a high volume of interstate commercial truck traffic. The other 2 highways that we're going to look at are the Lodge, which is M10, and the Southfield, which is M39. Those are more used for commuting, and while there are trucks on those highways, it's got a higher volume of cars. And so we defined 3 exposure groups. A group that's exposed to both high traffic and high diesel, and these people will live within 150 meters of the interstates. We're going to look at a high traffic but low diesel exposure group. So these are the people who live within 150 meters of the Michigan state highways. And then the comparison group is a low traffic, low diesel group. And these folks need to live at least 500 meters from the highway and at least 300 meters from a large surface road. So we started by taking the map of Detroit, dividing into different segments, and then along each segment, we literally walked down the street, knocking on doors, giving a survey, an asthma screening survey, trying to find kids of this age with asthma symptoms. And then we sent people with little GPSs out to define the comparison zones that are in the same neighborhoods, and again, walked down the street, knocking on doors, trying to find people with asthma of the right age and willing to participate in our study. Because this was such a massive ground effort, we did our recruitment in 2 waves. So basically, we recruited from even segments in 1 year, and then the next year we went back and recruited from the odd numbered segments. So this is our final enrollment. We had a final enrollment of 147 kids. So the study was conducted in 3 phases. The first phase, we just had the cohort 1 kids. The difference between the 2 numbers has to do with which health measures we collected from them. The kids in cohort 1 were then asked if they were willing to re-enroll in phase 2 and phase 3. We had pretty good retention, but after about 3 years, it did drop off. This is our second wave of recruitment. And so overall, we had a total of 147 individuals in the study for at least 1 year. All right, what was our health monitoring? So we had many different health measures or tools that we were using to measure health, measured at different intervals. We had a very detailed caregiver survey that was done once per quarter. We did spirometry or lung function measures up to 4 times in a 2-week period every season. We had a daily or twice daily symptom diary that also asked about medication use and impact on daily activities. We had a composite symptom score, a measure of exhaled nitric oxide, which is a gas that comes in your exhaled breath when you have lung inflammation. And then we collected nose mucus that we're analyzing in the lab for different kinds of biochemical markers of inflammation. In the end, we wound up with some fairly large data sets with which to do our analyses. So here's where I just want to pause and talk a minute about the key role that the Detroit partners played in this research. So you can imagine the undertaking that this recruitment was, and we're sending people out into neighborhoods. It was the philosophy of the group that we wanted to hire people from Detroit to be doing this, and that was because we needed somebody to open the door and to be able to engage with the person who's giving the survey, and we felt like having local residents were going to be much more able to make that initial contact. So trying to find and hire our staff to deal with safety issues. Immigration was doing a big sweep through Southwest Detroit around that time, and so people were very afraid to talk to anybody. So how do we contact, how do we let the community know that we're not the immigration police coming after you? Designing our surveys so that the language of the survey was understandable to our participants. Just sort of any possible glitch or barrier that we came across, the partners were really instrumental in helping us find solutions. Just a real quick, I'm going to go light on this just because of the time that we lost for the technical difficulties. We did a pretty standard descriptive analysis of our data, followed by modeling. We're using multivariate modeling techniques that deal with repeated measures in a longitudinal design. Primarily, we're using GEE. When we had continuous measures where the time trend was nonlinear in time, so we've got pollution that's changing in the background over time, and so the relationship between the things that we're looking at may change depending on what time segment that we're looking at. Then we're using GAM models. And finally, when we're looking at categorical outcomes, we used a proportional odds model feature. I will skip over the details of our model, but basically say that when it came down to evaluating the results, we could do pairwise contrast between any two different types of exposure group. But what I'm going to focus on today is showing you the conceptual contrast. So if you take people who lived along the interstates and compare them to the other two groups, that's a high diesel versus a low diesel contrast. Or you can take the two highway groups together, that's a high traffic exposure group, and compare it to the background group. That's the high traffic, low traffic contrast. We're adjusting for many things that can affect asthma-related health, including some structural things related to the study, and we're exploring for effect modification as well. All right, so here's what we're finding. And again, this is just kind of the tippity tip of the iceberg of our results. So here's our population. It's a school-age group of kids that's about evenly split between boys and girls. It's a predominantly African-American group. Detroit is segregated to some degree by ethnicity, so there are some neighborhoods where you can find people of Hispanic background and other neighborhoods where you're less likely to find people of Hispanic background. It's a very low-income population in general, with low educational attainment for the caregivers in general, very high level of secondhand smoke exposure. The CESD is a screening tool used to assess for depressive symptoms in caregivers. Higher score means more depression. These are sort of moderate level numbers, but it's no different across the population. These are values that these are characteristics that we will then adjust for in our models. From an asthma perspective, I'll just highlight that it's a high proportion of moderate to severe persistent asthma, and that was intentional. When we were recruiting people, we were trying to enhance to get the sicker kids in our study. Just to characterize the exposures a little bit more, so we plotted the locations of all the homes of kids in our study, and that they are color-coded based on the zone that they live in. So the green dots, I don't know if you can see that, are the people in the low diesel, low traffic areas. The red dots are people who live along the interstates, and the blue dots are people who live along the Michigan state highways. The figure on the left highlights traffic volume contrast, so the size of the circle indicates the amount of traffic that's going by that residence. And you can see that in general, both the Michigan state highways and the interstates have lots of traffic, especially related to the background folks. If you try to focus in on diesel exposure, these figures come from the Michigan MDOT, Department of Transportation, in terms of the volume of truck traffic on these individual segments. And as I said before, there are trucks on the Michigan state highways, but there's a lower volume in general than the truck volumes that are going on the interstates. But even the interstates are not all the same. There's some, when you're going south or west, you're going to get a higher diesel exposure. This is basically modeling of particulate matter exposures coming off the highway, and basically you can see there's a little hot zone right up against right near the highways. So this is just particulate matter concentration. The composition of that particle may be different depending on what the source of that particle is, whether it's a car or a diesel truck, but clearly the traffic volumes along the highways is generating a lot of particulate matter exposure. All right, so going back to our question, is living near a highway either the high traffic exposure or near a highway with lots of truck traffic, the high diesel exposure, associated with poor asthma health? So first let's look at lung function. Every time the kid blew into a spirometer, we had 5 different measures of lung function. The FVC is a lung volume measure and is not expected to vary with asthma, whereas the other 4 measures are different measures of airways obstruction, with the FEF 2575 being the most sensitive. And as you can see, 2 out of the 4 airways obstruction measures are coming up with statistically significant reductions in lung function associated with being exposed either to high traffic or to the high diesel highway specifically. If you ask people on a daily basis about their symptoms, common asthma symptoms, or the impact of those symptoms on their lives, whether they had to wake up at night, change their plans about what they were going to do because they were sick, whether they had to go to the doctor urgently because they were sick with asthma, whether they needed to use an acute bronchodilator or miss school, there's not as strong a relationship. Oops, my little significance line moved. Oops, sorry, moved. But if you visually put that line at the odds ratio of 1, you can see that there's significantly increased odds of needing an unscheduled doctor's visit for asthma if you live in a high traffic zone, and some hint that there may be a trend for some other impacts in the high diesel cohort. If you look at exhaled nitric oxide, that measure of airways inflammation that we can detect in the gas that you breathe out, we looked at this based on clinically relevant categories. So an FeNO level of less than 20 is considered normal, and that was our base category. There's sort of an intermediate category between 20 and 35 that's considered abnormal according to some folks and sort of borderline for others. But everybody agrees that 35 or higher is an abnormal measurement. And this is the proportional odds model. So there is a sort of 1.3 higher odds of being in a higher FeNO category if you live in the high traffic zone relative to the low traffic zone. And that's even more, that's a stronger effect if you live in a high diesel highway. So here, diesel in particular seems to be driving the lung inflammation. Okay, so just to quickly summarize that, proximity of home residence to highways is associated with 2 measures of airways obstruction, elevated exhaled nitric oxide levels, and an increased odds of having an unscheduled doctor visit with asthma. Similar associations are seen with kids living near highways carrying large volumes of truck traffic. We've got a lot of additional things that we can look at with this data set. Running over time, so I will scooch by those. Just a minute to talk about trying to do, I guess I would call it real-life environmental epidemiology. So the strengths of this kind of research is that you're looking at real-life exposures in highly vulnerable populations in a complex environment, and there's demand from the community to get this information. People want to know what's affecting their health, and this type of study can accomplish that. In our particular study, we were able to get an extensive array of different exposure and health measures that were collected longitudinally, so we can follow how these relationships change when the background levels of air pollution are changing, and also look at seasonal weather effects and time trends. And just this, I can't emphasize enough how important the partnership was to the success of our study. That said, there's a lot of legwork involved in this, and the recruitment challenges were enormous. This is a highly stressed population. They've got a lot on their mind other than participating in research, so retention and participation challenges took a lot of dedicated effort. But as you can see, we had a large data base in the end that I think will give us some very robust data for analysis. Okay, so I'm just going to end real quickly with, so what does this mean? So I sort of tell people, I can boil down my research to one statement, which is that air pollution is bad, right? But what are you going to do about it? So I think here would be, again, my suggestions, and this is me, not any of my sponsoring agencies, but I do think that supporting science-based air quality regulation is important. The Clean Air Act is under attack all the time, and so having people aware of what the issues are and being vocal advocates for enforcement and not gutting the Clean Air Act is important. There's certainly some health or public policy strategies, expanding and incentivizing public transportation and non-motorized transportation options. And then, assuming that people are going to drive, what can we do to reduce emissions? So we can change the fuel formulations, and that's been really important in the change in the composition of diesel fuel. There can be technology that can make emission engines more efficient and spew out less stuff. You can actually put a filter on the end of a tailpipe and sort of block what's coming out of the tailpipe. And you can certainly incentivize development and use of low or no emission vehicles. From a city planning perspective, knowledge like this can help you figure out where you want to put your school or your daycare center. There was a proposal once to have this transportation hub right at the intersection of several different highways, and they were going to make it wonderful because they were going to put the daycare center right there, so the parents take one bus in, drop your kid off the daycare center, get on the bus and go to work. And we sort of pointed out that that might not be where you want your toddlers to be playing. And then finally, mitigation strategies. So one idea is that, well, if the pollution is in these narrow bands, if roadway-related emissions exist in these narrow bands right near highways, can you do something to block or change the way that pollution gets distributed? And so there's been a lot of investigation of vegetative buffers, planting certain kinds of trees and plants along the highways that will essentially biofilter the air. And so I'm done. Thank you very much for your attention. And
Thank you very much. That was wonderful, Dr. Lewis. We have a little bit of time for questions.
I can also stay later. I just don't want to.